Hello, and welcome to the Relationship Dynamics of Cancer session of GVCC 2021. Thank you for making the time to be with us today. It's a joy to be able to spend some time with you and discuss this absolutely essential topic where we need to spend some time together to go through some things that are often not the stuff that gets said out loud. I'm Brad Love. I'm a GRIT co-founder and study exactly this topic at the University of Texas at Austin. So thank you again for spending the time with us. As you can see already, the chat function is a great way to continue dialogue about what our panelists are sharing. Also, an effective way to ask some questions and help us address the things that are on your mind. I'll ask you to please remember that all of our sessions are meant to be informational, so treatment decisions should be made with your healthcare team. But that said, let us dive in to today's topic. I'll start by asking each panelist to introduce themselves, and from there, we'll go into some of the key questions that are relevant to this area, as well as addressing what's on your heart and brain today. Rhonda, could I ask you to introduce yourself first?
Sure. Good morning, good afternoon, I guess, to everyone. I'm coming from the state of Ohio. My name is Rhonda Mextroth, and I am a seasoned caregiver. My husband was diagnosed with stage 4 lung cancer in the fall of 2015. So we are just starting year 7. And I'm also very involved in lung cancer advocacy and sit on lots of advisory boards and committees and work with lots of different pharmaceutical and industry. And I'm looking forward to today.
Thank you very much for that update. Kristen, could I ask you to introduce yourself next?
Sure. Well, my name's Kristen McMaster. I'm a social worker and have worked in oncology social work for about 15 years now. I live out on the central coast of California and am currently working for an organization called First Ascents. We take young adults impacted by cancer out on adventure programs, so surfing, rock climbing, and water kayaking. I've also worked at UC Irvine Cancer Center at their outpatient cancer center, and then also in the hospital setting. My main focus in oncology social work has been working in the AYA population, so with young adults 18 to 40 years old, but I've worked with people across the spectrum, so anywhere from folks in their teens all the way up into older adulthood, and am very passionate about this work in this field and all that it has to offer. So thank you all for being here today and taking some time to listen in.
Thank you for that. Dr. Duma, could you round things out, please, and introduce yourself?
Hi, everyone from Colombia, the country. I'm Dr. Juma. I'm the Associate Director of the Cancer Care Equity Program at Dana-Farber, and also a thoracic oncologist. We are particularly focused on women with lung cancer and the unique aspects of survivorship. I'm the principal investigator of the SHOAL study that closed to recruitment earlier this year, and is the largest study about sexual health in women with lung cancer. I want to thank all of you for inviting me, particularly to Dave, who's in the chat, who connected me with this great organization.
I appreciate that. Thank you. And thank you for tuning in all the way from Colombia. Could we start with you, Dr. Duma, and could we ask you to share your perspective, which is a foundational thing that we can stick on as a topic for a few minutes. Could you share why it's important to you as an oncologist to address sexual health with your patients?
So when we need to start looking at patients as a holistic matter. And one of the things that is very important is that the disease doesn't define our patients, and there are many aspects to their life. The disease happens to them, and that's what we're moving to a language in which we don't call our patients lung cancer patients, but patients with cancer. All people with cancer. So sexual health is an important part of health, and it should be seen like that, like your blood pressure, like your sugar levels, like your BMI. Sexual health is as important. Data most of the data does not come from lung cancer, but comes from other types of cancer, shows that the patients that are comfortable or they're fulfilled with their sex life during cancer treatments or after cancer treatments are less likely to require pain medications. So there has been a study in which patients that had a active sex life and they were comfortable with, and patients that the issues were not addressed, require higher pain medications and require higher medications for other symptoms. So I'm not talking about you only being sexually active, but it's also about how it affects your health and medications. It helps with pain, it helps with patient's mood, and also helps with relationships. Cancer disrupts the entire nucleus of the family. It not only disrupts the spouse, the kids, the grandkids, the mothers, the grandparents, every nucleus is disrupted. So keeping that connection with your partner significantly helps with the tension that is surrounding caregiver for a patient with cancer. When we talk about sexual health, we're not only talking about penetration, we talk about many aspects of sexual health: kissing, hugging, snuggling, and all those little touches that you can have with your partner that we create or maintain that emotional connection, particularly when our patients are being drained emotionally for cancer treatments, from visits to the doctor. So I have to say, I'm the oncologist that asks about sexual health. So people know that I'm going to ask when they walk into the door. But my dream is that this becomes a question that we ask. For example, we always ask, do you have nausea? Are you vomiting? Any diarrhea? We should include sexual health into that. Particularly, well, I focus on women, so I see mostly women, but particularly there are some aspects of sexual health that have consequences. Vaginal atrophy, vaginal dryness are associated with high risk of urinary tract infections or UTIs, right? So it's not only about the pleasure of sexual health, it's the benefits to your health as a whole. So we should ask, do you have nausea? How is your sex life? And no, everybody needs to be sexually active, but it needs to be addressed. Hope that answers the question. So many benefits.
It does wonderfully as an overview. Please, Rhonda.
I'm dying to jump in here. Oh my gosh. Like I can tell you, like I said, we were getting ready to start year 7. No one in the medical community that we've seen, and we've seen tons all over, have ever asked us any questions about our intimacy and our sexual relationship. And it's really a taboo subject that I am absolutely thrilled to death that Dr. Juma is leading, is passionate about it, and is getting us comfortable about talking about it and acknowledging it. And it's so important because when you have that stress and everything that's changing in your life, and then you start taking away the intimacy, that connection that you can have as a spouse, as spouses in this area. And a lot of times, not only are we not being asked about it, but sometimes it becomes a taboo subject, in the home. It's a very difficult subject, for both parties to talk about. So I'm thrilled. And I can tell you, like, as a caregiver, in caregiver groups where we're separated, from our loved ones, this is one of the number one topics that, oh my gosh, can we open up the door to, sexual intimacy and those kind of conversations that never get, discussed. So kudos. I'm so glad.
And I have to add up to that, the conversation can be awkward at the beginning, and it's okay to be awkward because we're not used to it. But the most important thing is if your doctor doesn't ask, you can bring it up. And I tell my patients, if you don't feel comfortable talking to me in person, you can send me a MyChart message. Because we know we are in a society in which we don't talk about it. So sometimes face-to-face can be challenging. So I'm like, go home, and if you have a problem, send me a message. You're not seeing me. Send it at 1 a.m. if you want. But I want to know if you have issues, because otherwise I cannot address them. I have seen women that have vaginal bleeding because the vaginal dryness is so high with osimertinib, right? And then I had a patient that had anemia, and we were worried why she had anemia, and it was the vaginal bleeding. So we have to address these issues, and there's many ways around it. If you don't feel comfortable with your oncologist, you can feel comfortable with your nurse, their therapists, and there are solutions. I think a lot of patients feel that the price of surviving cancer is that their sexual health is not important. And that's what I have felt, and which is like, well, I have cancer, I shouldn't be asked for that. It's like sexual health is like your blood pressure. Everybody, you get your blood pressure checked every time you come to the doctor, right? But I bet your sexual health is as important, because how often you check your blood pressure at home, right? Well, some people do a lot. But that intimacy, those hugs, Rhonda, that's also part of sexual health. Hugging your partner. I told my woman, hug your partner from behind and hold in, because you're going through so much, and just hold each other for 10 minutes. That is sexual health too.
Yeah, and it like I said, it's so powerful. It's so important for everything that you lose to be able to maintain that intimacy, that hug. That's how, couples, how you deal with, that's how you usually dealt with, it's a very important facet, of relationships, to be able to have that. And I do think there is this whole fear of, like in my case, it's male, but a lot of these therapies that you have to be on for cancer do cause, sexual, side effects or intimacy, concerns. So it's a very important subject.
And I'm just going to address something in the chat that says, my chart is not private. Yes, nurses and medical assistants can see messages. So you also can call your doctor and just have a phone call. Why did I suggest it in my chart? Because sometimes we feel ashamed in person. So I try to find ways around to communicate with them. And another thing before we move forward is that it's not only the side effects directly in the genital organs, is the body changes. So as I specialize in women with lung cancer, many of them lose their hair. And that's extremely important for your self-esteem and how you feel. You may not feel sexy if you don't have hair. So there are ways to find out how to address that, right? You may gain weight with steroids. Osimertinib, some of these new targeted therapies make you gain weight and you may lose confidence. So it's not only about, the organs, but it's about how we see our patients as a whole, right? And sometimes the caregivers feel, because I talk to both sides, right? They feel that they may break the wife, or they feel that she's fragile because she's getting treatment. So we talk about there's other ways to have sexual health that she can tolerate if he's short of breath, or that he can tolerate. So there's a lot of things that can be done. And my goal here in this talk is that it is not a price that our patients need to pay, or the caregivers. There are solutions, there are therapies, there are tools, toys, lubricants, name it. But if we don't address it, if we don't ask, we are not going to fix it.
Yes, thank you both. Kristen, could we turn to you and your expertise in this space a little bit? Specifically, if you wouldn't mind sharing, what are some of the coping strategies, as well as obviously the language strategies, for people that have relationships affected by their diagnoses?
Yeah, this question, I think, is one of the most challenging, especially when it comes to romantic partnerships. I think the reality is that cancer takes a huge toll on romantic relationships. And one of the biggest things I saw when I was working at the cancer center is that there's so much anger that people want to be able to direct at the cancer, but unfortunately we can't, right? Because it's this entity that is ever present, but not physically there. And so what often happens, in a lot of couples and partnerships is that anger, we tend to take that out as humans on the people who love us the most and who we think are going to be there for us. So I think one of the hardest things that I had to watch working in that space within oncology is that anger coming out, between partners or between family members or with friends, because unfortunately, our society doesn't have a lot of wonderful outlets for that anger. And so I think being really mindful of our expectations with our partners and what we want them to understand is really important. So one of the things that I think comes out in a lot of relationship dynamics is that we expect our partners to be everything for us when they really can't. And that's why it's important to have a whole network of people that you kind of draw upon when you're going through cancer treatment. So, it might be that your partner is wonderful at being able to hold you or touch you, but they have a hard time with the tough conversations. And so in those ways, it's important to draw upon like your nurses, your doctors, your social workers, other survivors to have conversations with. So you have people out there who can understand you, and you don't expect this one person to be everything in your life, because not just through cancer treatment and in survivorship time, I mean, it's important to recognize that that's true in any relationship, that one person cannot be, everything to you. And I think the communication piece tends, the burden kind of weighs right on the person going through treatment to be able to speak to their partners really clearly about what feels good and what doesn't feel good, and to be able to be really clear with them about what their needs are. And I think that's true in all relationships, being able to set boundaries on what help is, it feels good to them and what feels intrusive to them. And that was something I thought a lot about when I worked in the hospital setting. I think one of the things that came up the most was that a lot of people don't know how to cope with someone they love going through cancer. So they'll do things that they think are being helpful, but don't feel good to the patient. And so I think being able to set really clear boundaries with your partners or your families or your children, whomever, on what feels good for you and what doesn't is hugely important. And then finding an outlet for that anger, towards the cancer, rather than taking it out on the people who are there for you and who are supporting you. Finding a positive outlet for that is really important, so you're not driving away a wedge between you and the folks around you. And someone just pointed out in the chat, which I was thinking about when Dr. Juma was talking about the importance of just human touch, and how if there's anything, the pandemic has taught us, it's, a lack of just basic human touch and contact is so detrimental. It's so isolating. And the truth is, a lot of cancer survivors have been experiencing that forever. They all know what the pandemic has felt like because they've been in that space. And so now we've all gotten a small taste of what that deprivation feels like. And I think, as an oncology social worker, some days I would just go in and sit with my patients at their bedside and just hold their hand. And even something as simple as that can be really powerful, just that human touch and that contact, especially when people don't know what to say. We are lost for words. That human touch can be everything. Just holding your partner is so huge. So whoever pointed that out in the chat, I think that's a really good point, that the added layer of COVID has brought a lot more isolation and lack of just that human contact that we all crave as humans.
Go ahead, Ron.
Go ahead. I was just gonna say that, traditionally when someone thinks of, like what a caregiver's duties are, right? And today, like in my husband's case, like he's on a targeted therapy that really isn't like traditional, like what you think of like as traditional patient care. So he doesn't need those traditional things people associate with what a caregiver might do. And so I think I always tell people that it's about, like, obviously having, like you said, strong communication from the get-go, being able, and we set aside time to be able to sit down and really have honest, open communication about what his needs are, what my needs are. And I think it's really important to know that when you enter a cancer diagnosis, it does impact the whole entire family. And I think one of the biggest things that you can accept as a caregiver is what is my role in this new journey? Like that part, and how we used to deal with things and how our relationship used to be is changing. And I think accepting that change, and then figuring out where do we go from here, and how do we still meet each other's needs in this new way. And I think a big part of that too is still allowing, as a caregiver, to embrace caring for your loved one, but also giving them that space to still be an individual, right? And not feel,
absolutely. Yeah. Well, and I think for a lot of, people going through that period where there is so much role shifting that happens, acknowledging that the impermanence of it, you know, and just accepting it for what it is during that time is so important, because so often people want to grapple with that and have trouble accepting help. But I always reminded my patients, you know, that love that they get, that help, that caretaking is a reflection of what they put out in the world. It's just that coming back to you, you know. And so I think, and just one other thing I'll touch on, and I think this is so hugely important, and we've all experienced this, when there's communication breakdown and there's this elephant in the room that you and your partner are not talking about, it creates a barrier also in that intimate space. You know, it creates a wall between you, and it's really hard to break through that if you're not talking to one another. And the most common thing that happens during, you know, cancer treatment is this phenomena of it's called protective buffering, where we're kind of hiding our deepest worries or concerns or fears, all the what if conversations, because we don't want to upset our partners. We don't want to draw something into fruition by talking about it, right? There's that age old fear, when the truth is having those tough conversations, the what if conversations that you both are thinking about but you don't want to talk about, helps to break down that wall, both in the sense of like communication, but then it can also help in that intimate space to feel closer to one another, like you're in it together, versus creating more isolation between the partnership. So I hope that answers the question, Brad.
Brad, before we move, can we address the question in the chat? So somebody wrote that, what do you suggest for individuals who want to be active, intimate, but do not have the desire due to treatments or anatomical changes? 80% of desire comes from the brain, particularly for women. Sexuality is different between women and men, and 80% of desire interest comes from the brain. So decreased desire probably may have a background between that. So what I recommend my patients is, cancer happened, let's just go back in the past. When were you more interested in sex, right? So then we get, some people are more interested in sex in the morning, some people are more interested at night. So then my patients say, oh, I was into the morning. Okay, so now mornings. Let's go into the reality. How do you feel about sex in the mornings? When was your preferred time? Well, I don't feel interested. And then we write down what are the things that are affecting that morning drive. 80% come from the brain. So if you want to be sexually active, that's the first thing, the first obstacle that you're overcoming. So you really want that. But a lot of these things behind desire has to do with psychological aspects associated with sex, more than they are anatomical changes. So what is that is not making you feel what you used to feel in the mornings when you wanted to be with your partner? Well, my joints hurt because I'm in aromatase inhibitors, right? That's a very common side effect for breast cancer drugs, right? So then we find, what if we take a little bit of a leaf or some Tylenol right before? So there's things associated with desire because we worry about things happening. And women are very brain oriented for sex. We start thinking about a million things before we get involved in sexual activity. So where are the things that are worrying you? When you jump on the bed, the couch, where are the things that you worry? Well, I'm worried that because I have diarrhea for osimertinib, that I may have some gas during sex, right? That can be a real worry that just doesn't make you interested. Will you be interested in sex if you're worried about having gas during sex? Probably not, right? So address that with your partner and you say, I'm worried that I may have gas during sex because osimertinib does that. Or I'm worried that I'm not as flexible as I used to be because aromatase inhibitors just damage my joints. And let's don't even talk about the vaginal dryness or aromatase inhibitors because we're going to last the afternoon here. But talking to your partner about what worries you, we help you with desire. And a lot of my female patients worry about things that honestly their husbands don't even notice. I ask the caregivers, just like, she was worried about this, about what is that? And I'm like, okay, so then it's not a problem for you. So having a good conversation, like stretch marks, somebody wrote that. One of my patients' caregivers like, stretch marks? That means she gave me 2 kids. That's a badge of honor. So he saw it in a very different way than my patient saw it.
I think we've already picked up that there's a huge main theme here that all 3 of us are saying, which is strong communication. Not only even just among the family, the caregiver, the patient, but with like your medical team, your support system. Communication is the key, right? And you have to have those conversations, because if you're not having those conversations, they're going to be working themselves out in the ways like Kristen discussed. Yeah.
Rhonda and everyone, let's dig into that a little bit. If I could ask each person to share a little further. Agreed, communication for sure is the foundational point. One of the challenges with it, though, for humans is the first communication, the disclosure, the I'm having this challenge that isn't something I knew how to say out loud before, but I need to say out loud now. What's a good first sentence? How do I bring something up to my social worker, my clinician, my partner? What's the first sentence?
Go ahead, Narjit.
So I think your communications is two ways. And I think caregivers feel very guilty because they didn't figure it out earlier when the patient couldn't be diagnosed earlier. That's what a lot of the husbands verbalize, like, I should have noticed. And I was like, there is no way that you could have, so there's a lot of guilt there. And for the patients are very worried that the burden of being a caregiver is so large for their spouses. So when you think about it, those issues is just each other caring for each other. They love each other so much that their worries are about the other person. So I always like, let's talk about your worries. And sometimes I recommend my woman I call them my woman because I'm just so attached to my patients, to write a letter to their spouse, female, male, non-binary. Write a letter of what worries you. And those letters have done wonders because this is like, I love you, this is what I'm worried about. And doesn't mean you shouldn't talk to your partner, but it is hard sometimes to do that. And you come to a plan. Some of my patients, like, I practice in the mirror and I went and I said 20% of what I wanted it to say, right? So write a letter that can help both ways. And I would love to get Kristen input because I know as a social worker, I know as a psychologist, but the letter has worked a lot for my patients because they're so worried about their caregiver burden with their partners.
Yeah, and I think too, sometimes it's difficult to come out the gate, especially when with something like this topic, which is so personal and it is unfortunately still so taboo in our society. So if there's some fear or you feel afraid to kind of come out, out the gate with what your own experience is, I think in terms of talking to like your doctor, or your social worker, or other survivors or other caregivers, you can always start with posing a question, right? So you can always ask, like, in your experience, in your work, in your circles, has anyone ever talked about, intimacy or the impact on their sexuality or their own body? And you can always start with a question to hear from those people around you to kind of like open the gate to that conversation. And sometimes it helps to hear, like, I know, at least for me as a social worker, I'm always happy to share, and I feel it's a really powerful thing I can do for my patients is to share the stories I've heard and other experiences, obviously not giving out any identifiable information, but helping to kind of lay that out there first, what other shared experiences I've heard, and then it kind of creates the sense of comfort for that person to then be able to open up, to know that they're not the only ones thinking about this. So I would say for those who maybe have a hard time, starting those conversations, is you can always start with a question too, to kind of open the space for that. And just in terms of like exercises that I think have been really helpful, part of, I think what happens too is there's so much shame and we're really hard on ourselves, and one way that I've helped people generate some self-compassion and get over that critical part of ourselves is hearing their own story. So saying their own story out loud and then being an observer to that story and imagining what they would say to somebody else who is in that position. And that really helps people kind of generate their own self-compassion, which then kind of opens the gate to acceptance, right? Because that's the biggest thing, is being able to accept the changes within yourself. So those are kind of two things that come to mind for me. I hope that's helpful.
And I would say, like, if you're going to broach that topic, whether if you're going to be, in my case, if you're going to be a couple, a spouse, we're talking about sexual intimacy here, but I think that if you're going to be going to a counselor or you're going to be going to your physician, that really should also be a discussion prior to, in the home, so if I want to say to my, my husband that I want to be able to, address, sexual, dysfunction and how we may be able to deal with that, with the medications that he's on, I think it's important that not be, just something that's just, brought up, in that session. It should be a conversation that the both of you share at home and both feel comfortable about, bringing that up and how can we bring it up and not, and address it. And I think one of the key things that Jeff and I have navigated is that we definitely set aside time where we go up and we literally just lay in our bed and we just hold each other. We don't, initially, we're only just reconnecting to that, like that intimacy and that feeling that you get with just laying beside your partner and just like touching you, and just holding each other. And then that usually we segue into having these difficult conversations about what his fears are, what his anxieties are, what his needs are, and vice versa. And those are really powerful.
Agreed. Really appreciate the intentionality of that and, the elegance of that response and its sort of ease and simplicity, Rhonda, that can happen. If I could go back to something we were discussing a few minutes ago to come in your direction, Dr. Juma, one of the things that people have been discussing in the chat is how difficult it can be, or it can feel, not that it is, but it can feel, which is real, to discuss these kinds of things with their providers. As a provider, how can someone express relationship, whether platonic, intimate, familial, how can someone express relationship concerns with you? What kinds of things are you looking for? Can we give people some language?
So I have to say, I have a template in my clinic that I go over. So like they all get addressed because I have a template that includes financial toxicity, sexual health, family relationship, and meeting with the social worker, and also complementary medicine. So I created my own template. So every time in clinic, I open the note. I always pre-chart. It means like I review all my patients before clinic. So I remember, if the two lists were planted or because all these things are really important for my patients and they're very important for me. And I always do bucket lists with my patients. So I put it in my chart, and in the chart, I also have that list. So I go over the list. But sometimes there are so many things in the clinic, sometimes there's no one good encounter and it's forgotten. And I'll just say I don't ask every time because sometimes there's so many things happening. But I think if you get to know your patient very well, you know where things are not right. And I can notice that. Like how they sit, they didn't come with their spouse, something is happening. I have patients that have divorced during cancer treatment, and that can be more stressful. Like that divorce has to be measured as losing a significant other. So, these little things are very important. Even if your patient doesn't tell you, I always look for those cues and how things have changed over time. Because sometimes, I want my partner involved, and then they ask me they don't want the partner involved. So what's happening, what's going on? But what I often ask, and this is what I love telemedicine too, because it lets me see my patients in the real environment. Because before, when they come to the clinic, so I can see, is the partner engaged, is the partner not engaged, how many dogs they have, how many cats, because that's also important. The pets are very important, and it's also part of the cancer. I saw somebody has a cat, it's also part of recovery. But little cues help me understand that. I have it in my chart to ask my patients to see how things are doing with family and with respect. And I do treat a disease that's surrounded with a lot of stigma. So I'm very cautious of who they want to know when they have lung cancer, because unfortunately that is something that follow many of our patients with lung cancer. So I'm very careful about that because they may don't want every family member to know. And they shouldn't be like that because they're dealing with a terrible disease, and they shouldn't be dealing with this stupid, I'm sorry with the language, very stupid stigma with a disease. But that has helped me. And also, I have a wonderful nurse when I was at the University of Wisconsin. So she also spent a lot of time with my patients. And, sometimes you feel like, oh, it's the doctor, but like Amy and I were like sisters. So there was another person besides the figure of power that I have as the doctor. And they really help. And my nurse called all my patients like, hi, girlfriend, all the time. So then they develop a relationship in which I would get the scoop through my nurse too. Which it is important, because if it wouldn't, my main worry is that these things don't get addressed. That's my main worry. They don't get addressed, so they're not going to get fixed. And there's so many things that can be addressed, and our social workers are wonderful. There are many things that can be done. And before I end, I'm a cat mother too. My cat is not a quarterly cat. My cat has given me a lot of scars and actually put me in the hospital once for an infection in my arm. But I think having a pet really helps with many, many things. So I'm pro pet. As long as the pets don't lick the wounds, I'm good. It sounds crazy about the wounds, but it happened once.
Brad, just from a perspective of being like a part of a healthcare team and being in the hospital, I mean, I think if we could all be so lucky to have someone as welcoming, as a physician as Dr. Juma, that would be amazing. And we know that that's not always the case. And so I think something she said in her conversation was also looking to other team members and knowing that those team members who you might feel more comfortable with can be a voice in the ear of the physician. So if you feel more comfortable with your social worker or your nurse or the medical assistant, you could start the conversation with them and ask them to let the doctor know that this is something you would like to speak about. I think so often in doctor's visits, they come in with an agenda of the things they need to go over, which, let's face it, when you're going through cancer, so much of it is grounded in just helping you survive. And so they might not be thinking about that, but you have these other team members who sometimes you have more access to. And nurses too can have a breadth of knowledge about these things because they are talking to patients all day. So remembering that you can tap into those other team members if you don't have that rapport with your physician to be able to be comfortable enough to bring that to the forefront. I think that's important.
I can only imagine that Google is being inundated right now with searches of where is Dr. Juma? Where does she see patients? I saw somebody write in there, wow, I wish she was my physician. And I was literally thinking the exact same thing, like while she was speaking, and I'm so encouraged. That's why I love having these opportunities, right? For all these different patients and caregivers to be able to hear right? Like to be able to hear someone talk about, all the important things that she's talking about and the holistic view and the way that all the different ways that she's interacting with her patient and caring, wanting to have discussions and all the different things that she's, developed. If only every cancer family, could have, a relationship like that. Wow, what a difference it would make.
Indeed. And so in response to that question, we do have Dr. Juma's info at Dana-Farber in Boston as well. Just a couple of wonderful suggestions that I want to make sure get amplified. Shannon, I do believe, shared the Happy Partners Project cards, which are conversational prompts. Mm-hmm. I'm also putting in the chat the University of California, Berkeley developed 36 questions for increasing closeness, which are a sort of scripted dialogue of turn-taking questions people can ask to remove some of the work required to create our own questions, but to be able to make sure that there is space for that kind of dialogue. Please.
And I think it's really important too, there in the early, I would say in the first less than 2 years, Jeff and I really, really struggled with the dealing with our anxiety, our fear, our grief, not having good communication, depression, thoughts of suicide. And, we had to really sit down and think we need help here, right? Like this isn't something, and we did go and see, a counselor, like Kristen, to be able, both individually, so that we could have some freedom to be able to not feel like, oh, I don't want to say this about my partner. So, I mean, at that time, I was ashamed to be able to say that I'm depressed, that I have thoughts of like suicide, but and feeling shame that I can't handle this. Like, why am I not strong enough to be able to do this? And so having a someone who is removed, right, but also a professional to be able to help us both individually walk through that, and to be able to say, Rhonda, I think that not your brain isn't working, the way that it used to be. Things are changed. You're going to need, some assistance. And that's not a weakness to be able to say that you may need to be on, an antidepressant or, and we continued that counseling session for a long, long time until we could, get some good, healthy coping skills and understanding our trigger and warning signs and those types of things. So yeah, I strongly, strongly encourage it.
That definitely was one of my biggest roles in the hospital, was to be that middle person, to help facilitate those tough conversations. And it's not uncommon that the focus goes directly just completely on the patient, and we forget that the others around them are also going through cancer treatment. And so I think having that, as you described, the kind of individual support and building that rapport and then bringing it kind of together is so important, because when the caregivers get left aside, right, it's what a detriment to the whole unit and also to the patient. So I think doing it together in a group or as a family, as partners is so important. So I'm glad you kind of called attention to that.
Dr. Duma, may I turn to you, trying to recognize that you are scheduled to give a talk in not very many minutes, and we want you to have time to get some food and take some deep breaths. But I'd like to turn to you if there's a final comment that you'd like to make. I see you shared some writing that you did, and we all look forward to reading that. But is there a final comment that you would like to make to the group?
I think to all patients is none of you deserve this terrible disease. You didn't do anything wrong. This happened to you, and you're very strong by being here. That you shouldn't feel bad if you don't feel like you want to have sexual activity. That's also okay. And that sexual activity is on a spectrum. What Rhonda mentioned about laying down with her husband, that is sexual health. Hugging your partner for 10 minutes, we don't do that anymore. We're always in a rush. Just hold each other for 10 minutes. And also for the people that don't have partners, that sexuality doesn't have to have a partner. There are many things and many information. There are toys in different sizes, shapes, colors that can be used. And one of the great things about COVID is that you don't have to go to the store to buy them anymore, because sometimes you're afraid. Amazon, everything can be shipped right now. So there are many things, and there should be no shame in buying any sexual toys, lubricants, because that's part of sexual health. And in order to improve your sexual health, you may need that. And that is not like you're broken. And if you don't have sexual desire, you're not broken. You're just in a different phase. And sexual desire goes up and down. It has been associated with high sexual desire in certain times of the year. And that's what a lot of babies are born in certain times of the year, right? There's a lot of people's September birthdays. You wonder why. So there are many things that it can be done for sexual health. But the first thing is, if you have a problem, ask your doctor. It doesn't have to be your oncologist. It can be your primary care doctor, but they need to be addressed, because unfortunately some of these sexual disorders can get worse over time. So it's very important to address them early. Also, many women and men may lose confidence every day that the issue is not addressed. And don't let anybody tell you that hair loss is not associated with sexual health, because it is 100%. If you don't feel sexy, if you don't feel like you have gain, how are you going to have desire? So hair, when your nails peel for therapy, that also affects sexual health. So there is no one side effect that's better than another. They're all side effects, and they all can affect sexual health in a way or another. So they are all valid. Don't let nobody invalidate that some side effects can affect your sexuality. And happy to, the SHOAL study, which is the study that we did, is the largest study in women with lung cancer. The data is going to come out soon, and I hope that we can create interventions to fix the problem, because if we know the problem, we can fix it. So I still have 6 more minutes to stick around, so I will be here in the background.
Appreciate it. Thank you very much. Just wanted to make sure we made space for you. So thank you for the work that you do clinically and for the work you're doing to empower others at that event right now. It's wonderful to be able to have your voice. No doubt about that. If I may shift a little bit, Rhonda, you were sharing some really powerful, authentic, important things about your experience. And if you have space for it, and if you don't, it is totally fine. But I'd like to ask if you could expand a little bit to share what you wish people knew about the toll caregiving actually takes on a caregiver.
Well, I know I said earlier that I've never had someone, talk with us about, sexual, intimacy or relationships. But I've also, in our 6 years, never had someone turn to me and look in the medical community and say, how can we help you? Even, want to be able to say, is there anything that we can do for you? Is there any needs that we can help you with? A lot of times in the medical community, the caregiver voice is really basically ignored. So, that's something that you really have to, be able to, work through, because, and something I'd love to see changed. It's something that I advocate, for, that this cancer is a family diagnosis. It does impact everyone, even including your adult children. Everybody has a journey. Everybody has a disease. And in a lot of ways, Jeff and I talk about the fact that, Jeff has health side effects, but so did I, right? Like I was having, suicidal thoughts, having depression, not eating, he has a fear, I have a fear, right? It's like we have, and sometimes we would even have these discussions about, who has it worse, right? Like, he would talk about how he thought it would be and how he wouldn't want to be in my shoes. And so, I just think that what's really powerful about this kind of conference is that a lot of these are, people are hearing some of these subjects and thinking about it for the first time and thinking, oh my gosh, it's okay for me to go see a counselor. It's okay for me to have had suicidal thoughts, to be depressed. It's okay for me to, Dr. Juma, giving patients permission, giving caregivers permission to even think, oh my gosh, I'm not, I'm normal. It's okay, to be able to have this. And I think that in those beginning years, like I said, we really struggled. And so I think, developing, really recognizing, do you have good, healthy coping skills? Do you recognize your own body's warning signs and triggers, when you're heading there? And I want to say 2 really important things that helped me to move past that living in. So I was living in constant fear, constant anxiety, and my focus every day was about death. Right? Like, I couldn't get it out of my mind. And I was so forward thinking, what if this, blah, blah. And when I started focusing on making sure I had good coping skills, taking care of myself. And when I started being grateful and living in the day, and I know it sounds so oh gosh, blasé or whatever, but it is so true. When I started focusing on just living today and being grateful for the moment that we have today, it allowed me to be able to enjoy, when we were told in the beginning that, we don't know how long Jeff will have, could be months, right? And so and now here we are 6 years later. And if we didn't learn to be grateful and to live in the moment and to still try and, by buy this or take the vacation or, you know, do whatever. It's like being grateful, living in the moment, developing healthy coping skills were lifesavers, you know, for us.
Thank you for sharing that. We have a couple of questions from our wonderful squad of attendees. Specifically the first, and Kristen, I imagine you will have some commentary on this. Tanya asks, what about relationships between adult cancer patients and their parents? That dynamic sort of becomes the adult child as the needy one, and the parents are dealing with extreme emotion about the adult child's disease.
Definitely one of the tougher dynamics, I think, especially for young adults going through treatment. I mean, having to kind of fall back, right? Because in young adulthood, the focus is really on developmental milestones and where you are in your life, your career, you're going to school, you're developing independence. And so getting diagnosed with cancer and that during that developmental lifestone is it's a huge blow, and having to then fall back and rely on your parents to kind of take care of you again can generate like a lot of shame and a lot of resentment towards them. And I think that actually just one of my best friends just finished his leukemia treatment, and he's 38, and we just talked about this because he was being really hard on himself for he felt being unkind to his parents through his treatment because he was so angry that he had to rely on them in ways that he had grown out of. And I think that this is where that remembering of the impermanence of it, that this period of time, you might have to rely on your parents in a way that feels uncomfortable to you, but that it's not going to be forever. And it's to help you by Dr. Juma. It's to help you get through this period of time. And there will be an opportunity. And this is something that I just experienced as I shifted into that caregiver role with my parents. There will be an opportunity for you to give back to them at some point. But because you've been dealt this hand of having gotten cancer at a time in your life when you're not supposed to, it is okay to accept that help for this period of time, you know, and there will be opportunities to then switch back and role shift back into a place where you can then take care of them. So, and I think that using a third party is so important with parents, because one of the most common things I hear from young adults is they're afraid to set boundaries with their parents. They're afraid to talk about what they're going through because the parents then have such a strong emotional reaction to that it becomes more of a burden to them. Then they have to kind of manage their parents. And so I think bringing in a counselor or social worker or even a nurse that you feel comfortable with to kind of be there as a support to the parent to help them manage those reactions so the patient is not having to take that on is hugely beneficial, because otherwise there's total communication breakdown where the patient becomes afraid to say anything at all because they don't want to upset their parents and then have to deal with the emotional repercussions of that. So.
Yes, I very much appreciate that. I would like to continue this conversation. We have another question. Just before I do that, I want to acknowledge for those of you on schedules today that we are coming to the end of our scheduled time. It is not my intention to stop this conversation. There's too many important things to talk about. And we have a wonderful squad of participants who clearly still have important dialogue going on with each other. I will just say that from GVCC perspective, this is about the time for our interactive intermission, which will open on the GVCC website and have representatives from a range of organizations waiting to talk and support you live. We open back up in an hour and 7 minutes with a couple more sessions, one about making clinical trials more accessible to all with the focus on equity, or dealing with long-term side effects. And we invite you to attend both of those. That said, we have important things to keep digging into. So I'm very happy to continue doing that. Specifically, there is a question from Susan that says, when most of the treatment is finished, loved ones think you were all okay, but there are long-term side effects and some don't want to hear or believe. How can we approach people expressing that we are really not back to 100% normal? And Susan, I apologize. I sighed at the beginning of that question because this is one of the exact things that I study And it is such a challenge. So thank you for saying this out loud. Thank you for posing the question. I will pose that to our panelists as I seek to compose myself.
So the question is, Brad, that how do you kind of cope with that period of time?
Yeah, and approach people to express the idea that so often, for example, I find in my research, people have loved ones who say, oh, that's in your past.
Right.
It's over now. And the person in the situation, often justifiably, I would argue, wants to scream and say, no, there is no past. I'm different now. And thus these relationships need to be different. Boyd is referring to it as a new normal, which is language many people find helpful for sure. But how does one address that? Because there is no going back.
Yeah, I think one of the greatest learning experiences I had transitioning out of the hospital and going into a space and working with First Ascents where we're seeing people post-treatment. And one of the greatest learning experiences I have is that for so many folks, when they're going through cancer treatment, they're really unable to digest the emotional impact of it because there's so much focus on just getting through treatment and surviving. And then the moment when treatment is done, they not only lose their medical team, that support team, they're not seeing them as often. There's this idea from family and friends, right? That the treatment's behind you, you're okay now. And the truth is that that's when the emotional aftermath of cancer creeps up because you're not in that survival mode anymore. So it kind of tends to come spilling out. And that's when people, in my experience, feel the most isolated, the most depressed, the most kind of alienated from the world around them. And so I would say just in a practical sense, what I've seen be really helpful is for people to continue because there's kind of two things that can happen, right? As a reflection of that. Someone can either try and deny that it ever happened, right? And try and fall into that space where their family and friends are just pretending that the cancer never happened. And then that trauma will stick with you and it will absolutely affect you if you go into that denial space. I find that it's been very beneficial for the folks that come on our program to continue a relationship with the cancer community, even when you finish treatment. And it might be that allowing yourself to be in the space with other people who can see that first will then allow you the strength inside of yourself to carry that into your personal relationships. So oftentimes what will happen to the survivors who come on our programs is they feel heard, they feel understood, they feel seen in this sense by other survivors who get that the cancer never goes away, that experience never leaves them and is still very much present in their lives. And it empowers them to go home and then find that, ability to communicate that to their families and friends, that they're not okay, that they're still struggling. So I think creating a sense of normalcy within the cancer community first and other survivors allows them to develop that language to then bring that back to their personal lives to continue those discussions. I mean, this is an incredibly challenging question, but I have to say, I think feeling that within themselves and having that acknowledged within those communities definitely helps then carry on those conversations with families and friends back home.
Well, and I'll tell you personally, like I used to get really angry, right? Because people would say, oh, your husband looks great. There was this compassion fatigue. And in the beginning, I used to be really angry. And now I've realized those, it doesn't make sense because they don't know. So it's I shouldn't be angry if they've not walked in our shoes, if they don't live in our shoes, if they don't know. And so the really important thing that I did was to be able to look to connect with people that literally walk every day in our shoes. Mm-hmm. So that when it's kind of like why AA, works, right? Because you're sitting in a room, you're in a support system, and I now have we have a support system in place that allows us to regularly and have somebody that we can pick up and talk to be able to, it's just a relationship on a whole, and it will probably be your most intimate relationship that you will have when you can develop a support system and get people that are actually going through the exact same, whether or not that's a caregiver, whether or not that's survivor, whether or not that's just like families, but really having that. And I think, I'll end on a really interesting, controversial area was that I was so afraid of death and loss that I actually enrolled myself in a cancer widows group. And I know that people would think that that was really bizarre, but just the way that my brain works, I was overthinking and over processing and causing myself, just extreme depression and anxiety. And the really great thing is that when I first joined that group, and I wasn't somebody who had lost, but I wanted to feel, I wanted to see. And I've been able to now connect with 3 different women that I watched them go through from the beginning phase of the loss and that horrible grief. But I've also been able to watch them find their strength and find and move on. And that was powerful for me. And I know that it's very controversial, but it made a huge difference in my acceptance and my gratitude, and also understanding that I will survive this.
Sometimes I think confronting your biggest fear, right, can be the most powerful and healing experience, which is what that essentially is. That's so beautiful, Rhonda. And thank you for sharing that, because I've not heard that before. And something else you said just struck me so much, which is that this idea, I think, post-treatment of being okay that you're not okay. I think that acceptance, like within yourself, because I think what happens is there's so much shoulds put, well, you should be okay, you should be moving on, you should be doing this. And all those shoulds can kind of prevent the person themselves from being just able to accept that they're not okay, that they're not better, that they haven't moved on, and that acceptance within yourself is the first step to be able to then communicate that to your friends and family. So, and I think that's the piece you draw from in being in those communities with other caregivers or survivors.
Right. And accepting that you right, you said you have changed. Like I always tell people, like something happened, something broke, right? Like I'm not that same person. But like accepting that that's okay. I can't do all the things that I used to be able to do and take on everybody else's like responsibilities. I'm more limited, but it's okay. Giving myself the acceptance to say that it's okay that I'm different from this experience.
Thank you both immensely for that. I love that everybody is getting an opportunity to learn from all 3 of these different, dynamics in all of these really hard, conversations that we know it's really difficult for cancer families to deal with. Yeah. Thank you for putting this together. Mm-hmm. Agreed. It's a profound need in the world. And as you have shared, as Howard has just pointed out in the chat, it's okay to not be okay. We often have no other choice, in fact.
Yeah.
Because as Dr. Duma said, something was done to our people, to us. And that is just the reality of the situation. I want to, with all sincerity, applaud our 80-something attendees and the sharing and mutual support that was happening in the chat. That is how things get better.
Yeah.
That is how we reduce isolation and people's challenges. And so I encourage you, such as you have strength and capacity, to keep that up, all of you, please, because as you know, the world needs it. And this is where we are. I will keep the session open because, again, there's dialogue going on in the chat and I don't want to end the Zoom session, but I realize everyone might need a break. We've had quite an hour plus together of real beauty and import, but also work, emotional work. And so I encourage everybody, particularly while we have this break within GVCC, to stand up, move around, nourish your physical self with some movement, some helpful food, and to just bear in mind that these are important things to share. So thank you all for your time. Kristen and Rhonda, thank you immensely for sharing your expertise, and those of you in the chat sharing your lived expertise through your questions and support of each other. And we'll just sit for a minute to make sure the chat can stay open. And I look forward to seeing you at the sessions in 56 minutes, such as it serves you, as well as the wonderful lower key sessions this afternoon for joy and entertainment after we've done so much work together. So I thank you all.
Thank you, everybody. This has just been lovely. Be kind to yourselves.
It was a great opportunity for me as well, right? Like, yeah, getting to hear Dr. Juma and Kristen both. I mean, wow, both of them are spectacular in their presentation and information that, you know, in their experience. Yeah, it's as a cancer family, it's great to be able to, you know, have access to, you know, hearing and meeting people like this and sharing these. Yeah, it's very powerful. The opportunity of Zoom and conferences like this for everybody to be able to have access to someone like Dr. Juma and Kristen. Yeah.
Name back to you, Rhonda. Your voice is so important. We do our rock programs for caregivers for FD, and it is unbelievable the amount of weight that you bear going through cancer with a loved one. I had to go out and look at your, look at you, and your program and stuff that you work with. And oh, wow. Yeah. I'm so impressive. Thank you. Good stuff.
I look forward to connecting more. Yeah.
Yeah, I appreciate that. And
thank you so much, Brad. Thanks for moderating.
Okay, I'm happy to do that, of course, and happy to have everybody here at GVCC, where obviously we have lots going on the rest of the day, aside from the break now with the interactive session. And then for those of you who would like to continue connecting, I do just want to point out the last session of the day is a broad Zoom meeting where we have the most charming magician who's a member of our community. And so it is a chance to reconnect and to be able to chat with each other and see each other's little Zoom squares as well, which is clearly
support. Somebody in the chat asked about a hashtag for the next conference, but there actually is one for this one, right?
There is.
Yeah.
And Annie, there will be obviously a 22 as well as at a minimum monthly events that we do for support. Yeah, GVCC21 is the hashtag for this one, and there will be a 22 in addition to monthly events and more. And so we are certainly in regular touch through a range of media. Intentionally so, because everybody needs this.
Yeah. I was thinking that, social media, I think in a general sense can create a lot of isolation and more alienation when you're going through treatment, but connecting in this way can be so positive and such a nice respite from, yeah.
For sure. And, one of the things we see in the oncology communication research, broadly speaking, is digital media, whether it's a chat like this or what we'll just call curated social media groups, people feel more able to share.
Yeah.
Because there's some degree of anonymity.
Yeah.
And thus the things that maybe come with some social pressures or feelings of shame, even if those are not necessary or fair feelings of shame, that's just the way shame works sometimes, right. Or guilt or whatever. It's a little easier to get out sometimes in digital spaces.
Absolutely. And I think these are, so positive. And I told a lot of my patients to be mindful of where they're using their energy on social media, because they're sitting there in a chair getting chemo all day, watching your friends go out and live their lives and that can just kind of heighten that sense of what you're missing out on, but connecting in this way or with other cancer communities can really be the thing that saves a lot of people from that isolation. So it's kind of like this tricky balance, right, of kind of being mindful of where you give that attention to. So stuff like this, I think, is absolutely wonderful, and kind of buffering that, because I think now, you know, what's the most common thing we do when we're sitting around? We're on, you know, people are on their phones, or so you can get inundated with that in a really negative sense if you're on the wrong channel, so to speak.
Amen. And I think, you know, even aside from social media, like there was a part where I would feel angry about, you know, looking at our friends and couples, and that we're still able to do things that now we can't do. And that just kept me in a really bad, you know, headspace, because I was always just thinking about what we'd lost and not what we still have. Yeah. And that's just like it's not a healthy place to live.
Mm-mm.
Yeah.
Toxic.
Yeah. Yeah. I loved when we switched that, you know, transition to, you know, just being able to, that's okay. You know, it's okay that we can't participate in that event anymore, or that we're not invited to that, you know, event anymore because we're the, you know, the cancer couple, or, you know, we don't do this anymore, or that, or whatever. I'm like, yeah, just accepting, you know, that, that this is our new life, and, you know, being happy and grateful for all the things we do still have.
That's right. And what's gained, you know, I mean, I used to joke with some of my patients and say that I had survivor's envy, because I go to these conferences with like hundreds of survivors, or on our programs where it's a bunch of survivors together, and I watch this connection happen that's basically instant, right? When they see each other and they know that that person sees them and understands them. And I've studied this stuff, you know, I've met with hundreds, but I can never offer that, you know, that experience of understanding and having walked in the shoes, you know. And so I love that deep connection that happens, that comes from this experience. And I think that's one of the things to be gained, right, from going through an experience like that, is having those basically instantaneous, you know, deep connections with other beings who have this shared, really difficult experience that you can kind of draw upon. So there is something to be, and also recognizing the toxic relationships in your life that you can let go of and give your self permission to step out of, you know. So
I always thought Jeff and I had a really good relationship before the cancer diagnosis, and we were very fortunate that, you know, we put some tools in place and did some things to be able to help us get to a place where this just amplified, you know, our relationship, you know, to a whole, you know, a whole nother level. So I feel, you know, real grateful that we were able, you know, to navigate that, and, you know, and get to that space. And I think sometimes I get ridiculed for looking at things like from, you know, rose-colored, you know, glasses. Mm-hmm. But I lived in the space of being angry, being negative, being ungrateful, suicidal, depression, anxiety, fear. I lived in, you know, in that space, you know, for almost, you know, 2 years. And it literally almost, you know, I mean, it just wasn't good. And as soon as I could switch to this, looking at it like I'm not negating that cancer families' lives aren't extremely hard. They are, but it just helped me to be able to change that mindset.
Yeah.
And helped me to be able to live it, survive it. Yeah.
I mean, that's all you have control over, you know, at the end of the day, in this moment when cancer takes over, that's the only thing that you have left to kind of change within yourself, is your attitude towards it and how you look at it. So kudos to you for being able to make that, because not all couples can get there. And it is very tragic. And I've seen it so often, that separation, divorce, breakups. I mean, it is a tough thing to grapple with. And I think so much of it comes down to your attitude. So.
Agreed. Again, I thank you both immensely, as well as all of our attendees. In about 17 minutes, the interactive intermission will open, where we have this wonderfully broad range of organizations here to support all of you and be available to talk and support and chat, starting at 1:30 Eastern Time US. At 2 Eastern Time, we have those couple of sessions, one on clinical trials and equity, the other about long-term side effects. later this afternoon, some wonderful, powerful things that I have found are always worth hearing takes place at 3 p.m. Eastern, where community members will have 5 minutes to share their stories, and their stories that run the range of the cancer experience, and from which we can come to understand that we're not alone in our thoughts and feelings. After that is the interactive magic session, where everyone will have opportunity to connect a little bit further, and then our concluding conversation at 5 o'clock Eastern time. So I look forward to seeing all of you throughout the day. Thank you for being here. Again, thank you for sharing. And we look forward to spending more time with you and supporting each other later today.